ma'am. Good evening, ma'am. Good evening, sir. Now I'm going to present the case on infant with failure to thrive and breathlessness.
Yeah, please proceed.
Yeah, your slides aren't moving. Please move your slides.
Yes, ma'am.
Yeah. Perfect.
7-month-old male child, firstborn of non-consanguineous bandage, coming from Chennai, whose informant is mother and reliability is good, came with chief complaints of failure to gain weight and complaints of fast breathing for 2 days. History of presenting illness. The child was apparently normal till 30 days of life. Then mother noticed that child had fast breathing, which aggravated while taking feeds, and a suck cycle being present while taking feeds. The child was taken to a nearby hospital where the child was admitted and evaluated. The parents were told that the child had a congenital heart disease in the form of hole and prescribed oral medications and advised them to be on regular follow-up. At present, mother noticed that the child had fast breathing for 2 days, which is insidious in onset, progressive in nature, associated with chest indrawing, which worsens on taking feeds and not relieved by rest. History of forehead sweating was noticed by mother while feeding, and history of suppressed suck cycle being present. History of poor weight gain present. No history of bluish discoloration of lips and fingers. No history of decreased urine output. No history of abdominal distension. No history of fever. No history of nasal discharge or cough. No history of vomiting or loose stools. No history of seizures. Regarding the past history, during the 3rd and 5th month of life, child had respiratory tract infection and mother had taken the child to a nearby hospital and was treated as a OPD basis.
Sir, do you want to discuss the history of present illness, sir?
Yes. I just wanted to. So, what do you think? What problem do you think this baby has at the end of your present history?
So the child has congenital heart disease, sir.
Okay. So, I mean, there are just a few points which I would like to point out in your history,
Yes,
and
sir.
then I'll probably discuss how I would have looked at it, as a cardiologist.
Yes, sir.
See, I think history is very important, not just to pass your exams, but to decide what to do next with your child. Okay. So the way I'm going to describe is how I will ask a history for every single patient I see in my clinic. Okay.
Yes, sir.
So before I go into that, I just wanted to point out a few deficiencies. The first thing was you said history of breathlessness for 2 days, and then you say insidious onset. Okay. For me, insidious means the mother cannot put an exact date to when the symptoms started. Okay. So if something had been going for, say, 2 or 3 weeks, the mother will not be able to recollect whether it started on the 1st of May or the 2nd of May. But 2 days means it either started day before yesterday or yesterday. So the word insidious and symptom for 2 days don't go in at all. Okay. For anything less than 2 weeks, it cannot be insidious.
Okay.
And it cannot be progressive. Okay. So it's something which is of sudden onset and which has happened really acutely. And so when you have that kind of presentation, someone in whom you say has a congenital heart disease, there can be only 2 possibilities. It's either a lower respiratory tract infection or an arrhythmia. Now, there's absolutely no fever and there is no sudden change in the feeding. So that means that your history does not say it's lower respiratory tract infection. The only other possibility is an arrhythmia, which is very difficult to make out from the history. So I really don't understand from your history why this child has suddenly worsened over the last 2 days. Okay. Do you have a good explanation for that? Because the child was having heart failure for 7 months. He presented at 1 month of age, and then over the past 6 months, he has been going on with some sort of problems on and off. But why should there be a sudden worsening? So is there anything else to suggest a respiratory infection? Is there, even if there is no fever, is there some discharge? Is there some cough? Is there some some other symptom to suggest there's either an upper or a lower respiratory infection? I feel that you had not covered any of that in your history. So all of that need to be mentioned about why exactly the
Going
child
to
has.
present history only from now on. She hasn't talked anything about. She has only mentioned presenting symptoms. So you have to be patient enough to get this thing. So
But
she
you
has to,
want to past
she-
history also. So I'm assuming that the present history is over.
no. She is going to start telling everything now only. So
Oh,
she
she's
has
finished.
only given the first slide as a sort of introduction. Okay.
So the other thing which I wanted to point out is, Sakra-Sak cycle. So how did you ask the history of Sakra-Sak cycle?
When I asked the mother how long she's feeding the child, she said around 20 to 30 minutes. I asked whether she is able to continuously feed the child, sir. Mother gave the history like babies are able to suck for few minutes, then it is taking rest, like the child is not able to take the feed. It gets a pass and later it starts feeding again.
So why was the child not able to take the feed? Why did it need a pause?
Sir, the child was evaluated and
No. History, we are still in
diagnosed
history.
as a
Don't worry
congenital
about it.
heart disease.
So child was evaluated and diagnosed to have a congenital heart disease. So you got a history, you told history of Sakra-Sak cycle. Is that correct?
Even otherwise, you must be able to find out whether it's a cardiac cause or a respiratory cause. That's why we find out, elicit the Sakra-Sak cycle. So that you should, yeah.
Sakra-Sak cycle. See, if I ask every mother of a 2 to 6 month old child who comes to my clinic, almost every mother will tell me that the baby does not suck continuously, that it needs gaps between feeds. Okay. Unlike a newborn, after say once they are 2 to 3 months old, once they start fixing and looking at objects around, they will not be interested in sucking continuously at the breast. They'll suck for a few seconds and then the mother will have to coax them to feed again. So that might also be misconstructed as Sakra-Sak cycle. Okay. That is something which I see very commonly. A pediatrician asks whether they feed continuously, and then the mother says, no, it doesn't feed continuously. Then immediately they think it's Sakra-Sak cycle and send them to a cardiologist. But actually what happens in Sakra-Sak cycle is the baby becomes so breathless while continuously sucking that he has to pause. He'll be breathing really fast compared to what he was in the baseline. And only after his respiratory rate comes down does he go and suck back again as the breast. So you'll have to clarify that in your history, okay? You cannot just ask whether the baby is sucking continuously. And if the mother says, no, it doesn't suck continuously, you cannot say it is Sakra-Sak cycle. So that is one thing which I wanted to clarify. Okay.
So can I make a point here, sir?
Yes.
At this, you should find out whether the child is taking less volume per feed.
Yeah.
Becomes, as sir said, becomes unduly breathless during a feed, and the sucking is very shallow and not deep enough, and it is not able to sustain at the breast. So this vicious cycle continues over and over again. It's not a deep suck; it's a shallow, ineffective sucking. Becomes unduly breathless during a feed, and it is more profuse sweating happens during a feed. So these are the points. Then just asking vittu vittu paal kudikida, that anybody will say yes, even a nasal block as sir said can happen.
Yeah.
Need to do. Okay, proceed.
Shall I proceed, ma'am? Antenatal history.
Okay.
Antenatal history. During the first trimester, mother was 26 years primary gravida mother. It was a spontaneous conception. She was booked in a primary health center and folic acid tablet was given. Mother had no history of fever with rash during the first trimester, no history of any other drug intake or radiation exposure. Antenatal scan was done at 3rd month of gestation and was said to be normal. During second trimester, quickening perceived by mother at 5th month of gestation. Regular antenatal checkups were attended by mother. Antenatal scan done at 5th month was said to be normal. Iron, folic acid and calcium supplementation was taken by mother. 2 doses of tetanus toxoid injections were given. Mother had no history suggestive of gestational hypertension, gestational diabetes mellitus, hypothyroidism or any seizure disorder. During 3rd trimester, mother continued to appreciate fetal movements. Antenatal scan was done at 8th month and it was also said to be normal. No history of any bleeding or leaking PV. No history of fever. Mother continued take iron supplementation. Mother had adequate weight gain during pregnancy.
So again, I would just like to pause on this antenatal history.
Yes,
And, I think antenatal history is much more important nowadays than what it was a few years back. This antenatal history which you have presented might have been okay if you had done it, say, 15 or 20 years back. But today, as a pediatrician, there's a lot more information which you can get from the antenatal history, and which is not at all covered with what you have presented. Okay. So, for example, you have to ask very specific questions like whether there was any sort of screening for chromosomal abnormalities which are done. You would have read about how Down syndrome can be picked reasonably reliably based on scans and blood tests for the mother. So that I think should be covered in the antenatal history. Scans at 3rd month, 5th month, 8th month does not make any sense at all. Typically say whether there was an anomaly scan done, whether you will have to ask leading questions. So you will have to ask whether they check for any abnormalities in the baby, whether they said the baby was structurally normal or not. So in the 8th month scan, whether they were happy with the growth of the baby or not. I think there should be more specific details instead of just saying no radiation, no fever with rash, immunization received, scan done normal, no hypertension, no thyroid. I think that is just too generic, and that may not be enough for a pediatrician in 2021 in the antenatal history. So you'll have to go into the specifics. I agree a lot of our parents may not know the specifics, but I think you'll have to ask leading questions to get that out. And anomaly scans are done in most, even patients who get followed up in PSCs, the village health nurse or whoever is in charge of the mother's care make sure that the mother has a proper anomaly scan done in most PSCs, in Tamil Nadu at least. So I think those information should be picked up on with specific details, and it's not enough to just say a generic antenatal history, which you say for every baby, especially when there's a congenital abnormality involved. Okay.
Birth history. The baby was delivered at 39 weeks of gestation by normal vaginal delivery at Vembar Primary Healthcare Center. It was boy baby. The birth weight was around 3.1 kg and baby cried immediately after birth. Postnatal history. The baby was breastfed within 1 hour of life and there was no events or no history of any NICU admission. Regarding immunization history, the child was last vaccinated at 3.5 months of age at Vembar Primary Health Center. The child is immunized up to age as per national immunization schedule. Developmental history regarding gross motor, neck control attained at 3 months, rolling over attained at 5 months. Child is now able to sit with support attained at 6 months. Regarding fine motor, bidextrous reach at 4 months and unidextrous reach at 6 months. Social development, social smile attained at 2 months. Mother recognizes mother at 3 months and stranger anxiety attained at 6 months. Speech, cooing attained at 3 months and the child is able to speak monosyllables at 6 months. Age appropriate milestones attained in all domains of development. Diet history, child was on exclusive breastfeeding till 6 months of age. Complementary feeding was started 2 weeks back. At present, child is breastfed around 5 to 6 times per day and mother gives baby cereal powder 2 to 3 feeds per day. Mother mixes the baby cereal powder with boiled cow's milk and gives around 2 to 3 feeds per day.
What's your comment on the developmental milestones? Like in generally here in this child, it appears normal. But what do you expect in acyanotic congenital heart diseases? And you can quantify the significance of the left to right shunt based on the development or anything to some extent. Can you guess? What clues do you get from the development, like in cyanotic and acyanotic congenital heart diseases, which are significant enough?
Developmental retardation will be there and developmental delays will be there.
According to the domains. What happens in cyanotic and what happens in acyanotic of severe significance? What is usually affected in a significant left to right shunt? Which domains are affected and which are preserved?
Gross motor is mostly affected.
Gross motor is mostly affected. The other milestones would be pretty normal. If it's a cyanotic congenital heart disease, due to frequent hypoxia and cyanotic spells, they may have a global developmental delay. This is the clue we get. Okay, but since this child it is normal, maybe it's not a very large shunt. Okay, due to the physical activity of the infant, it has come to light with severe range and presentation now. Okay, so that remains to be seen. Right. So how many calories and proteins a child is receiving as per your calculation in the diet? Diet history, like there's an element of failure to thrive, isn't it?
Yes,
So you just have mentioned these are all the complementary feedings the child is getting, but actually you should quantify how many calories and how many proteins, grams of proteins this infant is taking. Where is that? Anybody else can help her? The other co-presenters?
Ma'am, this child is a predominantly breastfed child, ma'am. And they
Okay.
have just now started with the complementary feeds of just
Okay.
1 or 2 feeds per day. So she's, and that too the quantities, they have just now started with the complementary feed. So it is very difficult to quantify.
No, even
since
then.
the child is mainly on breastfeeds.
Okay, even then we can tell how much is the calorific value of that complementary feed, whatever it be, the formula feed. They're all standardized. So you can, and that is supplemented by breastfeeding, you can say. Even then there are some examiners who ask you, what is the average milk output of an Indian woman during the first 6 months of life and after the first 6 months of life? They ask you. So you must be ready to answer that also. Because within the first 6 months of life, an average Indian woman secretes 600 ml of milk, whereas it becomes half after the first 6 months of life. So 600 ml giving 400 calories roughly, 300 ml now giving 200 calories roughly. So there are two schools of examiners. Some of them will want you to quantify roughly how much the breast milk gives. So you have to add 200 plus you have to calculate for this cereal powder, whatever. So this also happens because all these years we're sitting through the exams, we face a lot of co-examiners and they ask you. You cannot say it is difficult to calculate. Okay.
Okay.
So you take this
Okay,
into
ma'am.
consideration. Okay, proceed.
Family
Proceed.
Family history, ma'am.
Yes.
The child is a firstborn of non-consanguineous marriage, and there is no history of congenital heart disease among family members, ma'am.
Okay.
Socioeconomic history, they live in a Paka house with 3 living rooms with adequate ventilation, a separate toilet and kitchen, drinks boiled canned water. There are no pet animals in home and mosquito nuisance present. Waste are disposed in common dustbin. Father has studied up to 12th standard and is a mechanic at present. Mother has studied up to 10th standard and is a homemaker. Capital income is rupees 15,000 per month. Belongs to lower middle class according to modified Swami. Contact history, no history of contact with open case of tuberculosis or COVID patients. No allergy history, no history of allergy to drugs or any food substances. Summary, ma'am. 7-month-old male child, firstborn of non-consanguineous marriage, who is a known case of congenital heart disease, diagnosed with 30 days of life and some oral medication at present. Now presented with fast breathing for 2 days, associated with forehead sweating present during feeds and without cyanosis present and with failure to thrive. There is no history of recurrent respiratory tract infection, no history of loose disposition of lips and fingers, without any significant family history.
Okay, what do you think of at the end of this history? So you must give a provisional diagnosis at the end of history, isn't it?
Yes, ma'am. The child is suspected to have a
Probably suffering from a
acyanotic congenital heart disease, ma'am.
Okay, what is as a PG you must tell about the probable severity even at the history stage. Do you think it is a mild defect, a moderate one, or a pretty large one?
It's a moderate to large one, ma'am.
Okay. Why do you say so?
The defect.
You're right. Why do you say so?
The child had the first presentation at 30 days of life itself, ma'am.
Okay.
And child was prescribed on oral medication to be on regular oral medication. Probably it might be an anti-failure medication, ma'am.
Okay.
And the child has poor weight gain, so child is failure to thrive, ma'am. So
Okay. So you feel it is a moderate, at least a moderate defect, isn't it? Now, as sir asked you, like, what do you think the sudden 3-day downhill course due to? What are all the factors? All along, it has been an acyanotic congenital heart disease, probably diagnosed at the end of newborn period. Why do you think only at the age of 7th month? What are all the factors which made the child present to you now with this acute onset breathlessness? What all might have been the reasons? Sudden downhill course over 3 days. Think, just simple.
Some precipitating factors might be there, ma'am.
What are they? What are they? Right.
Child might have got anemia, ma'am.
Very good. Anemia.
Anemia in 2 days causing acute respiratory
What
distress.
else? More probable. Left to right shunt, no?
Yes, ma'am.
A pulmonary plethora leading to respiratory infection.
Respiratory tract infection. Yeah. Lower respiratory tract infection might be. But then fever, significant fever is not there, isn't it?
Yes.
Okay. Or the child might have got aspirated, isn't it? Child might have got aspirated. They started complementary feeds. We don't know how they gave. Is it by feeding bottle or forced feeding with cup and spoon without proper technique? Oh, so a baseline incipient CCF might have got aggravated. That is also possible. Okay. And then more activity of the infant, isn't it? For 5 months and all, they'll not be so active. Now sitting with support, playing around like that also could be a reason. Anemia in 3 days, so there should be some acute blood loss for us to say if anemia occurred causing CCF in 3 days. Okay. So that seems a bit unlikely. Right. Okay.
And
Okay.
before the examination, I'd just like to give my perspective.
Okay, sir. Okay, sir.
Approach an infant with heart disease. So see, I may not have felt so when I was pediatric PG presenting cases, but an infant with a heart disease is probably the easiest case you can get to pass as a long case, because there are very few possible presentations in an infant with a heart disease, and you don't have time to develop a lot of complications. So there is very little that you need to get right to pass the exam. Okay. So if you have an infant with heart disease who has survived the neonatal period, then that means they don't have a duct-dependent condition. So you only have 3 possible clinical presentations. So the first is heart failure, the second is cyanosis, and third is cardiogenic shock. So these are the only 3 ways in which a child can present. So you need to ask history specifically to find out which of these 3 presentations your child has. So with heart failure, the main symptom is, feeding difficulty, fasting, cycle, as you said, forehead sweating and all that. But sometimes, especially in your child, was diagnosed at 30 days and was started on some medication, which was probably decongestive therapy. So it is quite possible that heart failure might be reasonably controlled. And that is why a lot of symptoms may not be very, very evident in the child. So you might need to ask some lot of leading questions to get the history right. So, for example, especially in a predominantly breastfed child, so you'll have to ask how long the child takes to feed. You'll have to ask the mother whether the breast gets completely emptied at the time. Say, mother says feeds for 20 minutes or 30 minutes, but she also says that the breast is not completely empty. She still feels full. That means even though the baby fed for 20 minutes, nothing really went inside the baby. Okay. And then you will have to ask how long the baby managed to sleep after feeding. So if you have a child with reasonably controlled heart failure who feeds for 20 minutes, it is likely that the baby didn't feed adequately and that the baby will wake every hour or so and ask for feed again once its breathing settles down a bit. So all of that will need to be presented in your history. It cannot be just, cycle, forehead sweating, that's all heart failure. That is not how it works. Okay. Then the age of onset of symptoms. So presentation with heart failure is possible in shunt lesions, as you mentioned, like VSD or large PDA or other large shunt lesions. But that might also be a presentation in cyanotic congenital heart disease with increased pulmonary blood flow. So cyanotic congenital heart diseases with increased pulmonary blood flow, the saturation will be around 91 to 90, sometimes even 95%. And cyanosis will not be apparent in an young infant, even to a trained cardiologist at 91 to 95%. The only way you can differentiate that is by measuring the saturation. So one way to differentiate between these two is typically cyanotic congenital heart disease increased pulmonary blood flow. The presentation is within the first 2 to 3 weeks of life. So by cyanotic congenital heart disease with increased pulmonary blood flow, I mean truncus arteriosus, single ventricle without pulmonary stenosis, unobstructed TAPVC. All of these, the onset of symptoms will be within the first 2 or 3 weeks of life. Whereas in your shunt lesions, typically it occurs after 1 month of life. There might be overlaps, yes, but that is one thing. You did mention that it started only at around 30 days of life. So that is one other thing you should ask in the leading question in the history. So the child was evaluated at 30 days of age. You should have asked them what the weight was at 30 days of age. Okay. So if the weight at birth was 2.9 kilos and at 30 days it was 3.8 kilos, it is likely that heart failure just started and the mother immediately went to the doctor. But if the birth weight was 2.9, after 1 month it was only 3 kilos, that means that the heart failure must have been going on for even 2 or 3 weeks earlier. So all of that need to be brought into the history. The other presentation for infant is cyanosis. So cyanosis, usually the weight will be fine, the feeding will be okay. The mother might have noticed bluish discoloration more during crying. So that, you mentioned bluish discoloration of lips and nails, but you should specifically ask whether that is noticed during crying, because especially with tetralogy where there are not too many spells, it may not be very apparent to the mother in the first few months of life. And you should ask specifically for cyanotic spell history, which you did not. Okay. And the third thing is cardiogenic shock. Obviously, a child with cardiogenic shock, you will not be presenting in an exam. So I think I can leave that for now. But these are the 3 possible presentations. And when you say the history, you should take the examiner into one of these presentations. I think you did not achieve that sufficiently enough during a presentation. I was not convinced by a presentation that the child had significant heart disease. You mentioned at 30 days, he was found to have a heart disease and started on some medication. You could have, most mothers will tell you after starting the medication, the child pees a lot, like passes a lot of urine. So you could have asked that history to confirm whether it was indeed decongestive therapy, which was started. And the child was diagnosed 1 month and now it's 7 months. You never told me whether they went back to the heart doctor, whether the dose of the medication was adjusted along with the weight. So I have no idea whether the baby is still in the dose of medicine which was started at 1 month of age, or whether it was progressively increased. You did not mention whether, what was counseled to the family about expectations from the heart disease, whether they were told that some sort of surgical intervention is needed or whether it is likely to improve by itself. None of this was mentioned. So based on history, I'm not really able to understand which lesion this child has and what sort of severity it is also. So all of this can be easily quantified just based on history. And at times you do have to ask leading questions to get these information out, because most parents may not really understand the significance of the symptoms or the significance of the intervention which has been provided to them. Okay. So these are some things which I would have expected in your history.
Yes, sir. But whatever it is, whenever the child is, whichever be the system, when we are dealing with a chronic disease, always at the end of history of present illness, before we embark on the past history itself, we have to tell something about the treatment history and how they went, whether they went for review, all these things. So that will give us throw much light upon what is the magnitude of the illness and what has been counseled. Any chronic case for that matter, treatment history is very, very important. Sequence through which the disease process is going. That's important, as sir well made out.
I proceed, ma'am.
Anything, ma'am? Sridevi, ma'am?
Yeah, can you elaborate on the failure to thrive? Does the mother know any weight recordings during immunization or anything like that? Is the mother aware of the weight of the child? How the pattern was?
My mother was not aware of the weight during the third 3.5 months immunization, ma'am. She was there.
Because in the history you mentioned that the child is failing
Not
to gain
gaining
weight.
weight.
That
How?
is just the mother's statement, or why is the mother feels so? Why does the mother feel so?
During the 5th month, when the child was taken for a respiratory tract infection, there the child was weighed and it was said to be around 4 kgs. So a mother, that they were informed that the child is not gaining adequate weight, and was mother came to know from that point.
Okay.
So that is the only weight mother can recollect.
Yes, ma'am. I questioned further, ma'am, but she was not able to recollect an answer.
Okay. Can proceed to examination.
Yes, ma'am. Clinical examination, general examination. The child was lying in supine position. The child was alert, awake, afebrile, pallor present. Child is tachypneic. Hydration is fair. The child is not icteric, not cyanosed, no clubbing, no pedal edema, or no significant lymphadenopathy.
Do you expect pedal edema in this child? Child is only sitting with support.
No, ma'am, I cannot expect pedal edema, ma'am.
So instead, what you should mention?
No ankle edema or sacral edema, ma'am.
Sacral, yeah. Presacral edema.
Presacral edema, yes, ma'am.
Hmm.
Vitals, blood pressure, record upper limb 84 to 46 millimeter of mercury, left upper limb 82 or 44 millimeter of mercury, right lower limb 90 or 44 millimeter of mercury, and left lower limb 90 or 44 millimeter of mercury. Heart rate 122 per minute. It's regular in rhythm, normal in volume, no specific characters, no radial or no radiofemoral delay, and felt in all peripheral axial vessels. Respiratory rate is 54 per minute. Temperature 98.6 degree Fahrenheit.
You should give your inference. Respiratory rate 54 per minute. What's your inference?
There is tachypnea, ma'am.
Should say side by side. You should say that. Okay.
Yes, ma'am. Child is tachypneic, and the saturation recorded in all four limbs, and it is 98% in room air, ma'am. Anthropometry, present height is 68 centimeter, which falls between 0 to -2 standard deviation. Weight 6 kg, which is on -3 standard deviation. Weight for length, it is less than -3 standard deviation. Head circumference is 45 centimeter, which falls between 15th to 50th centile, ma'am.
Okay.
Head to foot examination, ma'am. The head is normal in size and shape. There is no dysmorphic faces. Anterior fontanelle is open and flush with the surface. The hair is normal in color and texture. Eyes pallor present, conjunctival pallor present. Ears, nose normal, ma'am. Mouth, oral cavity normal. Neck normal. Chest, there is no deformity. Abdomen is not distended. The skin is normal. Upper limb and lower limb, including the digits, are normal. Genitalia is normal. Bilateral test is descended. Spine normal, ma'am. Clinical picture of the child, ma'am.
Okay.
Cardiovascular system examination. On inspection, the chest is symmetrical. Trachea appears to be in midline. Apical impulse seen in left fourth and fifth intercostal space lateral to the midclavicular line. There is no precordial bulge. JVP not elevated. No suprasternal, precordial or epigastric pulsations. No engorged veins or scar over the chest wall. There's no deformity. On palpation, tracheal position confirmed. Apical impulse felt in left fifth intercostal space lateral to midclavicular line. It is hyperdynamic in nature. There is no parasternal heave. Systolic thrill felt at left sternal border and third and fourth intercostal space. P2 is not palpable. Auscultation, mitral area S1 and S2 heard, there's no murmur. Tricuspid area S1 and S2 heard, no murmur. Pulmonary area S1 heard, S2 wide split which varies with respiration. There is no murmur. Aortic area S1 and S2 heard, no murmur. A high-pitched, soft-blowing pan-systolic murmur of grade 4/6 is best heard with diaphragm of stethoscope at left parasternal border in third and fourth intercostal space. No S3 or S4 heard. Other system examination, respiratory system, bilateral air
No,
entry plus.
from your cardiovascular system, what's your inference now?
Yes, ma'am. There is a apical impulse is hyperdynamic in nature, ma'am.
Location?
So I suspect the left ventricular
What does the
hypertrophy is
location
there, ma'am.
indicate? Yeah.
And the systolic location is shifted outward and downward, ma'am.
Okay. So which
And the
chambers are
systolic
enlarged?
thrill is felt in the left sternal border in the third and fourth intercostal space, ma'am. There's a pansystolic murmur of grade 4/6 is heard.
No,
in
no,
the
I
left
understand all
parasternal
that.
border in
What is your inference regarding the location of the apical impulse? Chambers. Chambers
left
affected.
ventricular hypertrophy.
Left ventricular
Left
enlargement
ventricular
and hypertrophy. Okay, right. Okay. Right, go on. Respiratory system.
Bilateral air entry plus normal vesicular breath sounds heard. Fine crackles heard over bilateral basal region and subcostal retractions plus one. Abdomen is soft, not distended, not tender, and there is no organomegaly. Central nervous system, the child is alert, awake, moving all four limbs and tone normal.
So
I come to my provisional diagnosis.
So I think I'll have to stop you at this point, doctor. I'll have to stop you at this point. I'm sorry to say I have to be really brutal with your examination. Okay. I will say this is the best cooked up case of congenital heart disease examination which we have seen. Okay. You have written these details not after examining the child, but after reading one of those notes, MBBS notes for clinical examination, and that too not the pediatric portion, the adult portion. Okay. There are just too many inconsistencies which I cannot accept at all based on your examination. Okay. I'll just go point by point because the first thing which I could not accept was radial and radiofemoral delay. It is impossible to look for radial and radiofemoral delay in a 7-month-old child whose heart rate is 120 per minute. So at that point, I lost confidence in your examination completely. Second, inspection, you were able to say trachea on the midline. So you mean to say you convinced a 7-month-old child to swallow to look for the tracheal position? Gone. Precordial bulge. What condition would you expect a precordial bulge to be present in a 6-month-old child? Absolutely no condition will have a precordial bulge. Again, gone. JVP elevation in a 7-month-old child.
cannot be seen.
You made the child lie on 45 degree and examine the JVP. Absolutely not possible at all. Visible apex in a 6-month-old child. Okay, sometimes if there's a really hypotonic phenomenon, you may be able to see the apex. But in most cases, the apex is usually confirmed only by palpation, not by inspection. Then you said suprasternal pulsations, epigastric pulsations, precordial pulsations. I would not expect any of these pulsations in a 7-month-old child. Now, sometimes the epigastric pulsations usually indicate right ventricular volume over. It's very rare for a 7-month-old child to have a condition where there's such a large right ventricular volume. Then engorged veins. Why did you look for engorged veins? What do you infer from seeing engorged veins in the chest wall? What congenital heart condition would you expect to have engorged veins in a 7-month-old child? Doctor? What condition would you expect to have engorged veins in the chest? Which heart condition? And then again, you mentioned no scars. So what scar were you looking for in that child?
Any previous surgical scar?
History
So you
says
mean
there's
to say
nothing
the
as
mother,
such, no?
mother will never mention a surgery? Mother didn't even mention a surgery to you. Is that what you're trying to say? And then palpation. So after looking for JVP and radial and radiofemoral delay, no 7-month-old child with stranger anxiety would have allowed you to confirm the tracheal position on palpation. Okay, so it's not possible at all. So, from that, I can very clearly say this inspection and palpation were written copied from a textbook. They are not from the child at all. Okay, then we'll come to auscultation. So generally, you know, the concept of mitral, tricuspid,
That's only for acquired.
is not there anymore. So there are only 3 areas we look at: apex, left parasternal border, and base. So the apex you look for things related to the mitral. At the left parasternal border, probably tricuspid and ventricular septum, and the base is the outflows. So it's very difficult to differentiate pulmonary and aortic. It does not mean if a murmur is best heard in the right side, doesn't mean it's an aortic murmur. If it's best heard in the left side, doesn't mean it's a pulmonary murmur. So, I mean, I'm not finding fault with all of that. What I would say is, don't go by this fixed notions of mitral, tricuspid, aortic, and pulmonary. They don't exist anymore at all. Okay. So you said first heart sound, and you said second heart sound. You just said wide split with expression. You know that the second heart sound has 2 components, isn't it? There's an aortic component and a pulmonary component. So you'll have to tell me whether how each component sounded, and whether the pulmonary was louder than the aortic or not. You mentioned P2 was not palpable. So even if there was really severe pulmonary hypertension, I wouldn't expect the P2 to be palpable in a 7-month-old. But you need to mention whether the pulmonary component, especially because you said there is wide but variable split. So when there is wide split, you should be able to make out the pulmonary and the aortic really well. So you need to tell me whether which component was louder or whether they were both the same. And you said, you beautifully painted in my mind that there is a significant heart disease, because you say respiratory rate was 54 per minute. And then you tell me there's a thrill. And there is a 4/6 pan-systolic murmur. So I'm assuming you're building everything towards this being a ventricular septal defect. So what does a 4/6 pan-systolic murmur tell you about the type of ventricular septal defect?
Moderate to large ventricular septal defect, sir.
Moderate to large ventricular septal defect will never have a thrill. Okay.
Only if it's a small one, the murmur will be very big.
Okay.
It's vice versa, no?
So what is the pitch of a murmur? You said high pitch. So what is the pitch of a murmur? What does it say? What does the pitch mean?
The
Intensity of murmur.
No, intensity is different.
Pitch is different intensities.
Quantify by 1/6, 2/6, 3/6, 4/6, 5/6. All of that, that is what is intensity, the loudness. But pitch is completely different. So pitch essentially tells you what is the difference in pressure between the, you get a murmur because of flow from one place to another place. Okay. So pitch tells you what the pressure difference is between these 2 places. So if it's a high pitch murmur, that means the pressure difference
small
chamber is very high. Okay. So if you get a high pitched murmur in mitral regurgitation, that's because the LV pressure is say 80 or 120, but the atrial pressure is only probably 15 or 20. So there's a difference of 100, which gives you a very high pitch. So in the same way, only if the difference in pressure between the LV and RV is very high. The RV is very low and the LV is very high. That is when you get a high pitch murmur in a VSD. So that means that VSD is very small. Whereas in a moderate or even large VSD, I would have expected the murmur might be loud, but it will still be a low pitch pan-systolic murmur. Okay. And then again, what is more, the other thing which you did mention no S3, but having seen that much cardiomegaly from your presentation and that much high respiratory rate, I would have expected there to be a third heart sound at the apex as well as a mid-diastolic murmur at the apex.
Flow murmur.
So you have to tell me why I expect this. Okay, I agree you didn't pick up it. I'm not going to blame you for not picking these two findings, but you will at least have to tell me why I expect to see these two findings at the apex.
Due to increased blood flow across the mitral valve, we can expect a.
Why is there
MDM
increased blood flow across the mitral valve?
There is an increased shunting of blood entering the pulmonary artery and increase the pulmonary blood flow, leading to increase the blood flow across the mitral valve.
That is fine. That's fine. Then the other thing, respiration. You said fine crackles. This child, I can bet, does not have fine crackles at the base. That is not how heart failure presents in a small baby. Okay.
Okay.
Crackles at the base is a sign of pulmonary venous hypertension. That is what you see in an adult with mitral stenosis. That is not what you see in a child with a large ventricular septum. Okay. Heart failure is because of the increased pulmonary blood flow. It's not because of increased pulmonary venous pressures. So that again made up. Okay. And then abdomen, even in a baby who has reasonably controlled system, I would have expected at least
Liver.
a 2 centimeter.
Bit of liver.
In a child who has planned heart failure based on your other findings and your history, I'm very sure the child has a reasonably large liver, unless the child has been so well diuresed by the time you saw that the liver has fibrosis. So there are just too many inconsistencies in every aspect of your clinical examination, which makes this completely unacceptable. So the feeling I get from this is, not only have you not examined this child properly, you have never examined a 7-month-old child, even a well 7-month-old child properly in your training, is the feeling I get based on this, okay? Which I'm sure is not the truth. So I think you worked too hard to make this a good case that you missed out on too many cases. I'm sorry if I've been really brutal, but it's I want you to learn from this experience. Okay.
It's a basic dictum that in children, in preschool children, we never look at the trachea. Tracheal position, we can never. That's why even for pneumonia and other respiratory illnesses, integrated management of neonatal and childhood illnesses concept came. It's pneumonia below 5 years. No child will be allowing you to keep the position correctly for you to examine the trachea, whether it is in the midline or not. That is why IMNC strategy came even for, we never do any tracheal position in a preschool child. Likewise, Nelson textbook itself gives that JVP is a fallacy below the age of 5 years and trachea need not be seen below the age of 5 years as a sign of mediastinal shift. These are all basic things. Okay, these mistakes should never be done. Okay. Right. So how do you manage then? And one more thing, for exam purposes too, whenever we say this mitral, aortic, pulmonary and tricuspid, all these area demarcations, they may hold good for if you get a case of rheumatic heart disease. We usually, how we teach in our colleges, for congenital heart diseases, when you examine, of course, inspection, palpation, percussion and auscultation, only at the end of it, you're going to say where you get the maximum hemodynamic findings. Whichever area, if it is upper sternal border, you can start your auscultation findings from examination of the upper sternal border. Say if it is pulmonary stenosis or if it's an atrial septal defect. If you're going to get the maximum hemodynamic findings in the lower sternal border, you begin your auscultation by saying examination of the auscultation of the left lower sternal border. Then they might ask you, some examiners might ask you, why you are starting from here. Then don't get perturbed. You say that you have dogmatically that you have maximum hemodynamic findings only in this area. Gently you say that, and I would like to start from there. So then it will not be a jumble. Then you can tell in all other areas, base of the heart, apex or axilla, whatever, the same murmur is heard in with reduced intensity or not at all, as the case may be. Okay, this would be better. For congenital heart diseases, you need not go by mitral, aortic, pulmonary, tricuspid. Even UG level, we teach them that way. Okay, that might be better. Okay, it holds good with what Sir says. Also. I think we have done. Okay, Sir.
F1 and F2, you just need to say S1, how the S1 was, how the S2 was. You
Yes,
don't
yes,
differentiate, this area, that area. Like here the S1 that well at the base. So there's no point in S1 normal at the aortic area and so on. So S1, S2, we just need to quantify. And then murmurs, as ma'am said, like I heard this murmur at this area, you just need to go away. So the way I will look at auscultation is not divided in the area. S1, that was normal, soft or loud. Sometimes, very rarely, like Epstein, you can definitely make out an S1 split very clearly. So in that case, you might need to mention, otherwise need to say S1 normal. S2, you have to be a bit more specific. You clearly whether it was single, whether the split normal or wide, whether it was fixed or variable, and you.
Okay.
Probably the same intensity or higher intensity.
Yes. Proceed.
Clicks. You can have clicks in bicuspid valve or in mitral and tricuspid valve abnormalities. And then you go to murmurs. So you go first with systolic murmur and then diastolic murmur. So you don't have to really differentiate into spaces. And as ma'am said, I think even in a UG level, this is how presentations go. So you don't have to worry about it.
Patient diagnosis. The case of acyanotic congenital heart disease.
Probably
ventricular septal defect with left to right shunt with congestive cardiac failure, without pulmonary hypertension, without infective endocarditis, with failure to thrive.
Okay.
So why do you say no pulmonary hypertension?
There is no visible pulsation in the second intercostal space.
See, whenever such a question is asked, you should try to get points from history, then from general anything in general examination or cardiovascular examination, that too from inspection to auscultation in order. That is the way it has to be. Immediately don't bank upon only your auscultatory findings. Okay? Please develop that habit. Even you can get a clue from the apical impulse. It's not just your P2 or whatever. Okay.
So whenever you have a large ventricular septal defect, it goes without saying that there is severe pulmonary hypertension. Okay?
Okay.
Because, when there's a large ventricular septal defect, the LV pressure gets directly transmitted to the pulmonary artery because there's no septum in between. So if you have a large ventricular septal defect, that means you have pulmonary hypertension. So don't bring in that quantification at all in an infant. Okay? Because I would have expected the P2 in this child to be really loud. So okay that you didn't. I think the smarter thing will be to not bring pulmonary hypertension at all into the picture when you present. Okay. And one more thing, failure to thrive. I think you need to quantify it better when you bring about a diagnosis as a pediatrician, not because it's the cardiac case. Ma'am, is it okay to just
protein
say
energy? Yeah. Protein energy malnutrition or severe acute malnutrition or whatever it may be. Likewise, you have to say, when you come to the cause, you might say that it's not due to dietary deficiency, it's a secondary element.
Yeah, you should tell your interpretation of your weight for length. What did you say, weight for
only
length?
Then we'll know the duration. Yeah.
It's less than -3 standard deviation.
So what does it imply?
It's severe acute malnutrition.
Yeah, you should tell that also. Include it in the diagnosis.
Yes.
Weight for age is affected, it is acute. Okay, length for age is affected, it is chronic. What about weight for length? That you didn't bring in at all, I think. When do you say acute or chronic?
Weight for age, acute one. Weight for length, chronic one.
Okay. If that stunted length also, weight is less. Length itself is stunted. For that length also, if the weight is less. Then it is
Wait
acute
for
on,
length.
yeah, acute on chronic malnutrition. So that you have to quantify. Okay. Right. 6 months crossed. No. What about the mid-arm circumference here?
12 centimeter, ma'am.
What is the inference based on that? When do you call SAM? What are the criteria to say SAM?
Weight for length less than -3 standard deviation, ma'am.
Okay. And or
mid upper arm circumference less than 11.5 centimeter, ma'am.
this criteria doesn't come in here, isn't it? For this child, you said it's 12. Okay. Then what else?
Bilateral fitting edema will be there.
Okay. What is visible severe wasting? Where all do you look for? Can you grade the wasting? Generally, how do you grade the muscle wasting? How many grades are there? Anybody to her help? Other co-presenters to her
PT
rescue?
Anushya.
4 grades. 4 grades.
Tell us. Yes. Are you saying? I can't hear you.
Grade 1.
What are the 4 grades?
What are they?
Grade 1 is buccal fat, loss of buccal fat.
That's the last one to go. You're coming retrospectively. It's from below upward, no? Anyone else? Where are the others?
Grade 1 is gluteal muscle wasting.
Yes.
Grade 2 is
that, and it will all come plus. Okay.
grade
1 plus.
Wasting in upper arms.
Immediately don't jump into upper arms. Buttocks and thighs. Then second one will be that
abdomen.
plus abdomen and groin. Then third will be that plus
upper arms,
chest and spine. Then that plus even buccal pad of fat. So this grading is very important. Suppose you don't have edema and mid-arm circumference is also not coming properly below 11.5 as in this child. Then if you don't know the grading, you will not be able to label a SAM as SAM. Okay. Right. Okay. So how do you manage? How do you investigate?
I would like to first investigate with a complete blood count and a peripheral smear, ma'am.
What do you expect?
Anemia, ma'am. I expect an anemia. And the peripheral smear showing anemia.
What kind of anemia? Child has got a chronic disease. Peripheral smear, what kind of anemia it will show?
Microcytic hypochromic anemia, ma'am.
Is it anemia of chronic disease?
Normocytic normochromic, ma'am.
Normocytic normochromic anemia. Suppose the child had been for a long time on cow's milk feeds, no? Here it's formula. Suppose the child had been for a long time on cow's milk feed, that to more than 500 ml per day, then you can expect iron deficiency. Then it can be microcytic hypochromic anemia. Right. What do you expect on chest X-ray, taking into account your apical impulse here? What do you expect? Apical impulse is in the left fifth intercostal space, isn't it?
Cardiomegaly will be there, ma'am.
Cardiomegaly, right?
Okay.
ECG changes in a VSD. Come on. What all do you expect? You are ordering an ECG. What all do you expect here?
Left ventricular enlargement. We see.
How do you make out? What are the waves you see? What is the voltage criteria to say left ventricular hypertrophy?
With the large S waves and V4, V5, V6.
Large, tall R waves in V5 and V6, ma'am. And tall, deep S wave in V1.
V1, ma'am.
Okay.
So at least in this group, what I would have expected you to say is, you will actually find biventricular force, which means you find R and S waves in, the
biventricular features.
V3, V4, V5. So what do you call that phenomenon as?
Katzwachel phenomenon, sir.
Large VSD.
So you expect biventricular force to chest X-ray leads. And chest X-ray, what do you expect to find on the chest X-ray?
Apart from cardiomegaly.
Dilated pulmonary.
I think you've got the chest X-ray. So you can...
Yes, sir.
Okay, what do you see here?
It's an AP view, over-penetrated film, ma'am, showing cardiomegaly. Left ventricular enlargement, ma'am. And prominent.
How do you say left ventricular?
CT ratio.
Cardiophrenic angle is obtuse, sir. So that the left.
I personally am not a believer of identifying the type of apex in an infant based on your cardiophrenic angle and all of that. So I think it's best for you to say cardiomegaly and not comment on the type of chamber enlargement, because it has absolutely neither sensitivity nor specificity, all of these things. Okay. So I will not go into type of apex in an infant. And what X-ray view did you say this was?
AP view, sir.
Have you ever seen an AP view being taken in a 7-month-old infant? Or even a 1-year-old infant, or a 2-year, or even a 3-year-old?
Sorry, sir. PA view, sir.
So that
I'm sorry, sir.
never been to go. It's not, huh? So you cannot take a standing X-ray in a 7-month-old. Okay.
Yes, sir.
So this has to have been taken only in a supine.
Yes, sir.
Okay, then go on next.
The pulmonary plethora is there, sir. Prominent veins.
How do you define pulmonary plethora?
So increased bronchoscopy marking.
How do you say it's increased bronchoscopy marking?
Normally, the central middle 1/3 will be from bronchovascular markings will be seen, sir. In this X-ray, even
Okay.
the periphery is filled with bronchovascular markings.
Good. But I mean, that is correct, but that is actually slightly less sensitive because it might change with the penetration and all of that. There's something else which is very specific for increased pulmonary blood flow or pulmonary plethora. What is that? I agree with your point, yes, but that can be modified based on the amount of penetration. So what is the other finding which you look for, and which actually you actually see a bit on the X-ray? What is it?
It's a hilar pulmonary artery enlargement.
Yes. How do you make that out? Not hilar pulmonary artery enlargement. It is the intrapulmonary vessel enlargement. So you look for that as, I'm sorry, I'm not able to point it out on the screen, but you should see an increased number of enlarged end-on vessels. Okay, especially on the right side, you can see a number of end-on vessels. So end-on vessels, which are the vessels which are seen en pass on the X-ray. So I'm not able to point out because it's somebody else's screen. But on the right side, you can see a number of really large end-on vessels, and that is the most important sign of pulmonary plethora in an infant, much more than vessels being seen till the periphery. Even on the left side, you can see a lot of end-on vessels, but they're much more clearer on the right side. Sorry, I'm not able to point out, but this is a really good X-ray to demonstrate that actually. And if you have
Here,
a
a
really
bit of thymus is also there. A bit of thymus is there modulating the heart shadow. Thymus consistent for age.
If you get an old-time examiner, they might even ask you what constitutes an enlarged end-on vessel. How do you define an end-on vessel to be enlarged? So actually, if you look really closely, every end-on vessel will be accompanied by a bronchus. There'll be a bronchus seen right next to it. You know, a sort of hyperlucent space seen right next to the vessel. And if that vessel is larger than the bronchus, that is what quantifies to be an end-on enlarged end-on vessel. I think you should probably go back and put this X-ray in an X-ray viewer and look for all of these findings, because they're actually nicely seen in this picture.
Okay. X-ray, ECG, then what do you do? What's the next step in evaluation? Echocardiography.
Echocardiography.
What is the aim of echo here?
To confirm the defect, ma'am. To find the size of the defect.
Okay.
To identify the shunt direction, ma'am.
Apart from that, how do you know that it's only a single defect?
To rule out other.
Not only the size. What else?
Rule out other associated defects, ma'am.
Right. It doesn't mean that there can be only a single VSD, isn't it?
Yes,
you can have multiple imaging where it is actually. You can see the size, site, type.
Yes,
then only comes the question of direction and all other things.
Yes,
quantification of systemic to pulmonary blood flow. Isn't it?
Yes, ma'am.
And then, as you said, any other associated anomalies.
Yes, ma'am.
Okay.
Yes, ma'am.
Then, what else? So many points you can get on an echo, isn't it?
Yes, ma'am.
What else?
Type of VSD, whether it is nearby the valves or any.
How do you classify VSDs?
Muscular.
Based on location,
membranous.
Yeah.
Muscular and membranous VSD, ma'am. Muscular, perimembranous VSD will be there, ma'am. Inlet VSD, trabecular VSD, outlet VSD, ma'am.
Okay. What else can you make out apart from all this? You said some other complication is not there in your final diagnosis.
Pulmonary hypertension, ma'am.
Pulmonary hypertension, you need to do something else.
And
what
infective endocarditis, ma'am. We can look for vegetations, ma'am.
Again, because you brought up infective endocarditis, would you expect infective endocarditis in a large VSD?
Or not? What do you need for an infective endocarditis?
Mostly it is seen in small VSDs where the jet
why?
is,
the jet is small.
VSD, the velocity jet will be high, ma'am. So it will impinge on the leaflet and it can produce infective endocarditis.
Okay. Then, how do you manage this child?
Since the child is in congestive cardiac failure, I'll give anti-failure medications, ma'am.
What are they?
I'll give diuretic therapy, ma'am.
Must be specific. What diuretic?
Yes,
how much?
Tablet. Furosemide, ma'am. 1 to 3 mg per kg per day, ma'am.
Okay.
2 divided doses. And to that I'll add tablets spironolactone, aldosterone antagonist, ma'am.
Why?
To prevent the cardiac remodeling, ma'am.
Come on, doctor. Again,
is it for that?
Potassium sparing.
The cardiac remodeling is only in cardiac.
Not the role of spironolactone.
So don't unnecessarily trouble same points. The only reason you add
Hypokalemia prevention.
you don't get hypokalemia. Okay, not for remodeling.
Yes, sir.
Then
How does diuretic help in, say, failure? What is the mechanism?
Reduces the preload, ma'am. Reduces the venous return to the heart and reducing the preload, thereby contraction will be effective, ma'am.
Okay.
Do you think the contraction will be abnormal in a VFP?
No, sir.
In long-standing cases with failure, the ventricular function may be decreased.
So
Also.
ventricular function will almost always be normal only, even in large shunt patients. So the only reason you add decongestive therapy is to reduce the circulatory blood volume so that the absolute amount of blood to the lungs goes down, so that you don't have feeding difficulty and all of that. That is the only aim of giving decongestive therapy. Okay.
Yes, sir. And to this, I can add a AC inhibitor to reduce the afterload, ma'am.
You should never give AC inhibitor in a child with a large shunt lesion. If there is one lesson you want to take from today, you should never give an AC inhibitor for an infant with a large shunt lesion. So let me clarify this. AC inhibitor has absolutely no role in a large shunt lesion. If you think you need to add an AC inhibitor, the child needs surgery or intervention to tackle the shunt lesion, not AC inhibitor. Okay. So there's only one point I want to clarify for you today. It is that you should never add an AC inhibitor to a child, to an infant who has a large shunt lesion. Okay.
Yes, sir. And, in addition, I'll give dietary advice, ma'am, to give calorie-dense foods.
No, if this is a large BST, this is not the ultimate treatment. No. Then how do you plan surgery? When do you plan? And is it surgery or you have occlusional device closure for this child?
When the weight gain is not proper, even with anti-failure drugs, surgery can be planned, ma'am. For this, device closure can be suggested.
Device closure? What are all the kinds of VST for which device closure is amenable?
For small muscular VSD without any valve involvement, mostly in perimembranous device closure is not advisable, as it can lead to heart blocks.
Okay.
As a pediatrician, I don't want to go into the specific, but as a pediatrician, if you see an infant with heart failure and a large VST, it means that the VST has to be surgically closed.
Closed.
Okay? So I think you'll be in safer territory to say that this needs to be surgically closed. You don't go into device closure in an infant, especially one whom you think has a large VST clinically.
Older child, favorable anatomy, all this matters for surgical closure. Here, first we need to see the location. It's a very small infant. Okay, large BST has to be done only surgical closure. Okay, right. Then coming to the nutritional aspect.
Coming to the nutritional aspect, I'll advise the mother to provide calorie-dense food, nutritive foods, and increase the number of feeds per day, ma'am, as a small multiple feeds, ma'am.
Do you advise direct breastfeeding in the acute stage here?
No, ma'am, I will advise the mother to give express breastfeed during this acute stage.
Supervised express breastfeeding. Okay.
Yes, ma'am.
How much of calories should you provide in the acute stage?
Around 150 to 160 kilocalories per kg per day should be provided, ma'am.
Is it possible in the acute stage? What do you mean by enteral support of a sick child? You know that BAG acronym, isn't it? In malnutrition, BMR, activity, growth, etc., etc. What all can you forego in the, suppose the child is in the ICU and is very sick with congestive cardiac failure. Even then, you can't provide the 150 calories per kg and all in that stage, and it's not necessary also. So, how much of your RDA will you need in the acute stage? You can forego certain things. What all you can forego? The quantification for activity and growth. That's not a concern at that time, the acute stage. So you can forego about 30%.
Okay, ma'am.
30 to 35% can be foregone.
Okay.
Okay.
Okay, ma'am.
So you need to give that only as thickened frequent small feeds, calorie dense, as you said. Okay. Then later, as the child is coming out of congestive cardiac failure, then you can slowly increase.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay. Suppose it is a SAM. Okay. What are all the ways of rehabilitation? This is by the way. So SAM also, sometimes they will leave alone the CHT, get into SAM. Okay, in the examination. So what are all the steps in the management of SAM? Just enumerate.
Hypoglycemia correction, ma'am.
Okay, next. Just enumerate. Hypoglycemia correction. Next one.
Hypothermia, ma'am.
Correction. Then
electrolyte correction, electrolyte imbalance correction.
Imbalance, right. Then
micronutrient deficiencies.
Okay.
To treat infections, ma'am.
Management of infections. Then nutritional
Dehydration
intervention.
correction.
Nutrition correction.
Okay. Here comes the role of family counseling, isn't it?
Yes, ma'am.
Not just seeing the child as alone. You must see the family as a whole.
Yes,
so that also matters.
Yes, ma'am. Yes, ma'am.
What preparation
Okay.
will you start with for enteral treatment,
Yes,
enteral
yes.
feeding? Sam?
Sam,
At 75,
what is that? How much does it provide? Calories and proteins?
it provides 75 kilocals of
Per 100 ml. Then
and, 100 ml and 12 grams
protein?
of protein.
Protein?
12 grams.
How much protein per 100 ml?
12,
2.4
F75.
grams.
We are shocked.
12 is too high, ma. You
Madam,
can't provide
2.4.
12 gram in 100 ml.
How can you?
2.4 grams.
It's a decimal. It's a decimal. Which is the largest decimal? 0.9.
9.
Then it becomes whole number. 0.9. Not to catch clues at least.
You got confused between F75, F100.
F100 itself 2.9 only. Then where is the question of 29 and 69 and all? 12 and all. Okay. Right. So this is how you give. Right.
Just one point which I want to make as a cardiologist for
Okay,
the
sir.
learning of all the PGs. The first neutral, if you have an infant with a large shunt lesion and such bad failure to thrive, the first nutritional intervention you need to do is to close the defect. So till
Yes,
then,
sir. Yes,
whatever
sir.
you do, the weight is not going
It's
to
not
gain
going
at
to, yeah.
all. And once you close the defect, you don't have to really do any of these interventions.
They'll grow on their own.
So, most, at least as a cardiologist, we never have time to talk about diet to a patient after VSD closure. But when they come to us for review 1 month later, I've never seen a child gain 1 kilo in that 1 month interval. So, you cannot say that in an exam, but this is an important take-home point for all the PGs. The
Well taken.
only nutritional intervention the child needs is closure of the shunt.
Yes. Then anything else, ma'am? We are almost 8:56 now. The time is almost 9. Anything else like to highlight?
What are the complications you expect after surgery in the case of VSD?
After surgery, we can expect a residual shunt in the VSD, ma'am. A residual shunt in the defect. Conduction block, ma'am. Complete heart block we can expect, ma'am.
Okay. Anything else, sir? Dr. Mani?
Just for PGs to understand this, all of these complications are almost unheard of in modern surgery. I've been a cardiologist for 8 years. I've probably seen one heart block in 8 years in a large VSD. And residual shunts, which are as important as to need a second intervention of some kind. Again, I've probably seen one patient in 8 years. So all of these are more theoretical things. I guess you should probably mention all of these in an exam. But for you to understand, once you close the VST, you probably cure the patient for a lifetime. They almost never have any significant problem in the future. Okay. And again, you had mentioned CAT study in your list of investigations. I've never seen an infant with an EST undergo a CAT study. CAT study is not necessary, okay? It is probably what you will find in PARC, because PARC got trained in an era where echocardiography was just coming around and where most of the diagnosis was still being done by angiography. So you don't do CAT at all in an infant with a large VST. So again.
Yes, sir.
Thank you, sir.
Yeah. Over?
Yes, Dr. Rajendran.
Yeah. So, on behalf of IAP TNS, I thank one and all for this excellent presentation. And I invite our judges, Dr. PRC sir, to comment.
Good evening.
Presenter can stop sharing the screen.
Yeah, you can stop it. Yeah.
Good evening, sir.
Good evening.
Dr. Geetanjali here. Good evening.
Yes, ma'am. Yes. Thank Dr. Geetanjali, Dr. Maniram, and Sridevi for coordinating the presentation very well. And Dr. Nandini, who is the presenter from KMC, I presume, no? From KMC. Okay.
Yes,
So,
sir.
yeah. So this is see, we have not had, I think, recently any cardiac case presentation quite some time. So that way it is very useful for the postgraduates. Please take it as an exercise. See, the examiners or whoever it is, they are talking with about 10, 20, 30 years. My professor probably is 40 years experience. So this is for you a learning period. So it is a good that you present repeatedly and hone your skills, and whichever the areas you think improvement are required, you please do that, because this is nothing like what we do in our day-to-day examination. It's a presentation is something which you'll have to do with your friends. So now that you are having chat and other things, probably you present to your friend and just ask her to find out how your presentation has gone. What are the areas which require improvement? We need not be the judges. You yourself can be the peer judges and improve your presentation skill. So this is a wonderful opportunity for you. Now that you have the screen time, you can do that. And I like this thing, comments made by our judges. I mean, as a candidate, I never like my teachers pointing out my mistakes, but it helps not only me, for all my colleagues. It is not only directed towards any one of you. It is generally mistakes like this we do commit, we do see in our postgraduates. What is just not possible, those are all the things which are included in the examination. Okay, they will tell about an 8 month, 9 month child like this. In CNS examination, they will talk about corneal reflex and other things, which are just not possible. Okay, unless the child is totally moribund, you cannot do that. So certain things you can't do in an active child, but you are all scared because you don't want to miss anything. That is the problem. No? So take the examination as your day-to-day examination, how you will do, how you will approach, what is feasible, and from that, what do you make out the diagnosis? If you go with that approach, probably it will you will get more credit. And also the examiners will like you. They will know that yes, this is a person who has worked in the ward. They know what is possible for a child, what is not possible for a child. So please bring in your day-to-day practical knowledge, whatever you are doing into your examination. Don't go by only by what is given in the clinical methods. Don't try to put everything of that. Okay, that is nicely brought out by your examiners. So these are all the common things. Sometimes we fail to correct. Okay, so we are not doing it sometimes in your daily clinical examination. We let go. We just say that, okay, the candidate is presenting, let her or him present. But it's a good thing that is pointed out. So you be practical and what is feasible only you present so that it add more credit and weightage to your presentation. Okay. So there are a lot of good interactions. Okay. So I like the way you are generally brought out all the important things, points and other things. And I would have expected more participation from your colleagues also. Okay. So the questions others also, if they had answered, it would be nice. It would be a good team effort. So thanks once again, Dr. Professor Geetanjali,
Thank you,
Mani,
sir.
and and Dr. Sridevi for a comprehensive
Thank you, sir.
discussion. Thank you so much.
Thank you, sir. Dr. Srinivasan, sir, please.
Yeah, it's better to make mistakes now rather than doing it in the examination. And it is good that these mistakes have been pointed out for the other people also who are listening, all the PGs. So it's not necessary that we have to present everything in a very fantastic way that no mistakes are found out. So sometimes it's essential that you purposefully make mistakes so that you are getting corrected so that others also will learn. Okay, so these are the things, and take it in the right spirit. It's not criticizing in any way. So, of course, it has shown that you have to read a little more about cardiology. Probably nowadays, children are immediately operated upon and interventional measures are taken. You don't see as many cases as
Hectic
we
these
used to
days.
see those days. That may be the reason. Or immediately these cases are transferred to specialty
Special.
units. So that way you are not having enough experience to present these cases. What Dr. Ramachandran has just now mentioned is that as much as possible you try to see and I'm sure there is time to improve and you have not done a bad job. So it's good that these mistakes have been pointed out at this time instead of being pointed out in the examination. Okay. So when you are learning driving, so it's always nice that there is somebody to point out what is to be done, what is to be. That's what exactly has been done so that these mistakes are not repeated again in your future. Thank you so much. I'm sure the other two partners also would have learned and also the other PGs who have been listening to this would have learned by this. Thank you so much.
Thank you, sir. Dr. Janani, madam.
Yeah, it was a good presentation, and I think I enjoyed listening to Maniram. I mean, Maniram as a teacher. My student becoming a teacher, it was a pleasure listening to him. I think that's how it is in the exams. I think Nandini, we should understand that you will have a pediatrician and a specialist in the exams, and